third year junior resident at Ramakrishna Mission Position, Vivekananda Institute of Medical Sciences, will present the case. And with us today is Professor Saurabh Ghosh, who is Professor and Head of Oncosurgery Department at Calcutta Medical College. So Anish will present the case. End at the after history, you will wait. We have some discussion in the history part, and then examination, and then discussion on the management. So Anish will share your screen and present.
Slides wallpaper gallery. So is it visible?
Yes.
Yes, please.
Okay, thank you, sir. Good morning to all of you. Today, I, Dr. Anish Kumar Pandey, going to present a case on thyroid carcinoma. I am a third year PGT from Ramakrishna Mission Seva Pratishthan, WIMS. Sir, should I start?
Please.
Yes, sir. Thank you, sir. The patient particulars is Mrs. X, 50-year-old female, resident of Kolkata, housewife by profession, presented to us with chief complaint of swelling in the front and the sides of the neck for the past 6 months and the hoarseness of voice for last 15 months. History of present illness. Patient was apparently asymptomatic since 6 months back when she noticed a swelling at front of the neck. The swelling was insidious in onset, initially small in size, gradually has increased and involved both sides of neck, right-sided more than the left. There is a history of rapid increase in the size of the swelling from the last 1 month associated with slight hoarseness of the voice from the last 15 days. It is not associated with any pain or the compressive symptoms. There is a no history suggestive of hypo or hyperthyroidism and thyrotoxicosis. There is no history suggestive of the distant metastasis like bone pain, jaundice, and the hemoptysis. Sir, should I proceed? Hello.
Maybe you can elaborate a little on what are the different symptoms or signs that you look for to decide that not have hypo or hyperthyroidism.
Sir, for the hyperthyroidism. Sir, for hyperthyroidism, I will look the patient build. I ask for the patient appetite. I look for the patient is whether irritable. Patient is having tremors or not. Patient is.
This is history. You are not asking for looking for tremors. You ask for features in history. You have not yet reached examination. What are?
Yes. Sir, Hello. Hello.
Yeah, Dr. Ghosh is asking, what are the symptoms you inquire from the patient to say that yes, this patient has got some symptoms of hyperthyroidism? You see, you should go systematic. Go with the GI, then cardiovascular, then neural. So each of the system is being affected by hyperthyroidism and patient have symptoms pertaining to the particular system.
Sir, I will ask for the patient's appetite, whether it is normal or increased. And I will ask the patient about the weight, whether he is losing weight or there is a difference in the weight. I'll ask about the patient about the bowel habits, whether there is a constipation or diarrhea.
Correct.
Sorry, she's female, so I ask about the menstrual history, whether there is oligomenorrhea or menorrhagia. And sir,
but she is 50, so maybe periods in her case will not be.
Sir, I will ask for the loss of hair.
Yes, that is a feature of.
Go systematically. GI you have completed. Then come to cardiovascular.
Yes, sir. I'll ask about the patient. I will ask patient about the palpitations or in palpitation or tachycardia. Sir, I will examine in the general examination.
So palpitations, dyspnea,
restlessness. Yes, sir. Dyspnea on exertion. Facial edema, sir. Facial or pedal edema,
will
sir.
Not be able to say.
Yes.
Swelling of feet or swelling of face. Yes.
Swelling of face, yes, sir.
In the history, as far as possible, don't use technical terms. Use general terms, which the patient will.
Yes.
Okay. What else? You said loss of hair. Loss of hair is a more characteristic feature of
hypothyroidism, sir.
Hypothyroidism. Any particular area?
Sir, lateral side of the eyebrows.
Eyebrows. Okay, fine. Then what else?
Then,
what
sir,
about intolerance to heat or intolerance
yes,
to cold? Will you ask that?
Yes,
So
sir. Yes,
these
sir.
are important common
yes.
features that you must ask.
Yes, sir.
Okay, carry on.
Anish, you are allowed
Yes.
to write one line regarding hypo and hyperthyroidism, but it should be prepared. Once
Okay.
examiner asks you what are the
Yes.
symptoms, you inquire to say patient does not have symptom of hyperthyroidism. You should clearly mention all the points that one should take in the history to come to a single line of saying no symptoms of hyperthyroidism. So, and as I said, you go systematically. GI symptom, menstrual symptom, cardiovascular symptom, neural symptoms. So don't make it haphazard. You go by system. Each of the system has some features of hyperthyroidism. And you said a patient has got hoarseness. And another line you said there is no compressive symptoms. How do you say that?
Yes.
Sir, also, maybe either infiltration or compression. Yes. Compressive symptom may be dysphagia, dyspnea, and hoarseness.
Yes, hoarseness.
Okay, so don't say one patient has got alteration of voice specifically. Don't use that term that patient has no compressive symptom.
Yes, sir. Yes.
Okay. And again, distant metastasis, you said there is no symptom of distant metastasis like
bone pain, jaundice, or hemoptysis.
How common is jaundice in a patient who has got liver metastasis?
It's very less, sir.
Yes.
And liver metastases itself are not very common in thyroid cancer, although it can happen. Thyroid cancers most commonly go to the neck nodes or the mediastinal nodes or lungs or bone also in case of follicular mucus. So, anyway, carry on.
Carry on.
Yes. Now we come to the past history. There is no history of concurrent medical illness, and there is no history of any irradiation. Family history, there is no history of thyroid, head and neck, breast, colon, or any other malignancy.
Why do you ask for colon malignancy specifically?
Sir, for the medullary carcinoma, sir, in the associated with the Cowden syndrome. So there is a chance of medullary carcinoma, and we find in Cowden syndrome, sir, we found
there is an association of papillary cancer with FAP. You know FAP, familiar adenomatous polyposis coli. That is associated with you. And any thyroid cancer can be Cowden syndrome, but Cowden syndrome is very rare. I don't know whether sir has ever seen a Cowden's or not.
No, I have not seen.
FAP, we maybe see one FAP in 3 years or 4 years. We get to see one FAP.
Sir, you are not audible, sir. Hello?
Please carry on.
Yes. Sir, now we go to the personal history. Sir, she's married. She's on mixed type. There is no history of substance abuse. Normal bowel and bladder habits. Sleep is normal. Menstrual history, menarche at the 12-year, menopause at 4 years back. Regular cycles. She has 2 living child. Now we come to the general clinical examinations. Patient is examined in a well-lit room after obtaining informed consent and explaining about the process. She is conscious, alert, cooperative, and well-oriented to time, place, and person. Performance status was 90 by Karnofsky. She is well-built. BMI is of 24. Hydration status is adequate. Heart rate is 68 per minute, regular, normal rhythm, and adequate volume. Blood pressure is 138 by 76 millimeter of mercury in right arm supine position. Respiratory rate is 14 per minute. There is no pallor, icterus, cyanosis, clubbing, or pedal edema. Lymphadenopathy is found and is described in palpation. Sir, should I go for the
local examination? Yes, please.
Now we come to the loco-regional examination. On inspection, swelling is situated in front and side of the neck, right side more than the left side in the thyroid region, extending laterally up to the sternocleidomastoid in right side, superiorly up to the thyroid cartilage, inferiorly above the supraesternal notch. The surface is nodular, margin is ill-defined, mobile with deglutination, but not with protrusion of tongue, no skin changes, scar, sinus, or the fistula, no engorged veins, no venous prominence over the chest, no visible pulsation is seen. Now we come to the palpation. Local temperature not rest, swelling is non-tender, swelling present in the front and the sides of the neck. The isthmus measures approx 3 cross 2 centimeter, right lobe measures 5 cross 3 centimeter, and the left lobe measures 3 cross 2 centimeter approximately. Surface is nodular, margin is ill-defined. The swelling is hard in consistency, skin over the swelling is normal, the swelling is non-pulsatile, not fixed to skin and underlying structure and moving with deglutination. There is a no tracheal shifting and Cocker's test is negative. Carotid pulse is normal in position. There is a multiple lymph nodes are palpable in the right deep cervical group at level 3 and 4, firm and mobile. Examination of the cervical spine within normal limit, oral cavities, no any abnormality detected. On percussion, resonant tone heard over the manubrium sterni.
Before percussion, could you go back to palpation again? Yes. So it's a local temperature nodular swelling, surface nodular, margin is ill-defined. Hard swelling, but margin is ill-defined.
And even in thyroid, let him complete, then you can discuss from inspection.
Okay.
You finish up, Anish?
Yes, sir. Auscultations are no bruise is heard. So the my provisional diagnosis is a 50-year-old female with thyroid swelling, clinically euthyroid with cervical lymphadenopathy with slight hoarseness of voice, may be probably malignant in the nature.
Come back to the localization inspection. Yeah. You see, once you are doing this examination and you are seeing swelling in the thyroid region, in PG level, you can straightaway say that this is a enlarged thyroid gland seen because you have a classical butterfly shaped swelling in this patient.
Yes, sir.
Okay. And
yes,
if you have a butterfly shaped swelling, why do you want to the protrusion of tongue test?
Yes.
Once you have a swelling which is involving the both lobes in the isthmus, do you think there is any possibility of this being a thyroglossal cyst? This is not required. Try to understand. If it is a solitary thyroid nodule, one swelling in the one of the lobe, that is a place where you do the test of protrusion of tongue. Otherwise, in a butterfly swelling, this is not required. I prefer that you straightaway say thyroid gland is enlarged and visible, located in the thyroid region.
Yes,
right lobe extent is this, left lobe extent is this, and the region isthmus is this. What do you feel, Dr. Shora? You describe the thyroid.
Actually, so maybe you can avoid doing it. But what I was more interested in is in the palpation. Have you mentioned that you can feel the lower border of the swelling? Can you feel it or not?
You have not mentioned about
that. You have not mentioned that is very important. If I am palpating the thyroid, or the one thing I am looking for is whether I can margin or not, and the second is whether it is deep to the adherent to the underlying structures. These are the things which will decide my operative approach. So you have not mentioned that. That is very important. Surface where it is nodular. I mean, in the exam you have to describe all these things. That is fine. But from the treatment point of view, it is very important to know whether there is any intestinal prolongation or not. Because for that I may need to make certain arrangements. So
and second thing, he is saying the swelling is hard in feel, and most of the time you find the thyroid swelling, you can feel all the borders. If you press one lobe on one side by Lahey's method, the other lobe become more prominent. So it is not difficult to find the lateral border, upper border, particularly.
Let us ask him what is Lahey's method. How did you do this examination, Dr. Anish? From standing in front, what was the patient's position? What was your position?
So patient was sitting. Patient was in sitting position and examined the patient from the front side by the Lahey's method only, sir.
This is inspection or palpation you're talking about?
Sir, in both, sir, inspection and palpation.
Okay, so inspection, when he was standing, did you ask the patient to keep her head down or head neutral or head back up?
So I will keep the patient head slightly extended, sir. Not
head
so much,
slightly
but
extended, and the hands behind the neck. That is known as.
yes.
That is known as. There is a name for that.
Sir, ये
Yes,
Pigelo's method,
starting
sir.
with P. Yes, physical correct. Good.
This is done in patient
And
having short neck.
Yes.
Where you ask the
Yes.
patient to extend the neck and head behind the head is a Pizzillo's method.
It will become more prominent. Even in a normal neck also, it will become more prominent if you do it. So you will have a clear view. Achha, palpation, say you did from front. That is known as.
Lahey's method, sir.
So can you describe it? How exactly you palpate it?
Sir, in Lahey's method, sir, I'll for palpating the right lobe, I will push the right lobe towards the right side and palpate the right lobe from my left
How
hand.
will you push? How will you push?
Sir, from the palm of my right hand.
No. You push
Right
the
hand.
left
So
lobe. Try to understand. You don't push the right lobe. You push the left lobe to the right, so that right lobe become more prominent. You don't push the right lobe.
Yes, sir. Yes, sir. Yes, sir.
So you push you push away the right lobe more to the right side by pushing on the left lobe, as I said, and then you palpate the right lobe with your
Palm, sir.
your left hand, not
Yes,
the
sir,
palm,
left hand,
the
yes.
fingers also. You will
Fingers,
the
yes.
posterior lateral aspect. Posterior aspect, you have to go behind the sternomastoid and hook your fingers and palpate it. Lai described this method in I think this is American surgery, AJS, in 1950s or something. That article is available on the net, where he is described with photographs and all. He says all the surfaces can be very well palpated. From the posterior approach, there is also one way of palpating thyroid from behind, which we most commonly teach in MBBS students. But in that, the posterolateral border, the posterior surface is not so well appreciated. Lahi claims that by this method, you can feel the posterior surface of the gland, any small nodule or irregularity on the posterior surface of the gland better by Lahi's method. Okay. You said Cocker test. What is Cocker? I think you mentioned Cocker test.
Yes. Again, Cocker test is not to be done. That is another thing. Don't try to demonstrate Cocker test in your clinical examination routinely. Okay, this patient may go into distress. You said initially patient has no comprehensive symptoms. The swelling is for 6 months. Okay, so there is a minimal chance of patient having tracheal lumen being narrowed in this patient, and that should be found out on investigation. A clinical test of Cocker is not encouraged to be done in routine examination. Don't mention that. No examiner will ask.
Sir, we have not to mention in examination.
No, you said Cocker test is negative. I felt somewhere. Just go.
Okay, sir. No, sir. Means we have not to mention, sir. From the next time, sir, we will.
No tracheal shifting and Cocker test is negative.
Yes, sir.
That is what I'm saying. You did not mention about Cocker test at all.
Okay, sir.
Where did you test for carotid pulse? Where did you check for carotid pulse? You have said carotid pulse is normal. Where did
sir, normally, sir, carotid pulse is checked on the anterior border of the sternum at the level of the upper border of the thyroid cartilage.
Achha. And what happens if it is abnormal in position or lost? Do you know what is that called?
Sir, Berry's sign.
Berry's sign. Which kind of problem do you get Berry's sign positive?
Sir, Berry's sign, when there is a infiltration of the tumor, sir, to the carotid artery, then we will not get the carotid artery pulsation. So
engulfment of the carotid
engulfment
by
of the
malignant
carotid
tumor.
artery,
Yes. Okay. Generally, in anaplastic cancers, you will get. Okay.
How do you exclude that the swelling is not fixed to the underlying prevertebral muscle in the cervical spine in this patient? What is the clinical test? That swelling is either fixed or not fixed to the underlying prevertebral muscle and the fascia.
Sir, if the swelling is fixed to the prevertebral muscle or fascia, then swelling will not move with the degglutination at all.
That's it. Very good.
And all.
So, if the swelling move with deglutition,
yes, sir.
Can the swelling be fixed to the larynx and trachea by infiltration?
Yes, sir. Swelling can be fixed. Swelling can be fixed to the larynx and the trachea, and also it moves with the moves with the degglutination.
Yes. So this by deglutition test, and second is if you move the swelling side to side, up and down.
Yes, it will not move when it involves the larynx or trachea.
without any maneuver. Okay, just as such swelling is fixed. The swelling is infilling into the pivotal muscle and the cervical spine. Okay.
So, okay, what are the swellings? What are the next swellings which move with deglutition? Move up with deglutition?
So thyroglossal cyst moves with the deglutination. Any thyroid swelling moves with the deglutination. Subthyroid bursitis, bursa moves with the deglutination, sir. Any lymphadenopathy arising from the trachea or the larynx moves with the deglutination.
Lymphadenopathy doesn't arise from the trachea or larynx. Adhering to the larynx.
Yeah.
Then what else? Laryngocele also moves with deglutition.
Laryngocele.
Okay, fine. Carry on, please carry on. What next?
Sir,
before you go to provisional diagnosis, you should make two headings. Examination for retrosternal prolongation, as Dr. Ghosh said. The swelling lower border is palpable. There is no engorged veins over the chest wall, and Pemberton sign is negative. These are three tests you should do to exclude retrosternal prolongation.
Have you done Pemberton's test? What is Pemberton's sign, or what is Pemberton's sign? How do you elicit Pemberton's sign?
Sir, we asked the patient to raise his both his hand, peeping, touching both the ears, and we asked the patient to stay like this for 1 to 2 minutes. And
anything to do with respiration?
So
what can happen? One, you say the test is positive.
Yes, sir.
Take a deep breath. We ask the patient to take a deep breath. Why are you asking the patient to raise his or her arms?
Sir, to see the any compression of the great vessels of the.
But why the raising of the? There is compression. There is compression. There may be compression. While why not ask him to pull the hands down? Why ask them to raise their arms? Or why not ask them to keep them by the sides?
Sir, by raising the hand, we see the whether there is a obstruction, so the blood will not flow from the from the superior side.
So if there is an obstruction with the arms kept down, the blood will keep flowing. If there is a significant obstruction,
yes, sir,
and the arms are kept by the sides, then the blood will keep flowing. I mean, the only way the blood can be stopped is by raising the arms.
Yes, sir. Yes.
Actually, you see, Anish, there is a confusion in this point. Some people say that if you raise the hand, thoracic inlet get narrowed. But one point against it, thoracic inlet is a bony inlet. So by just simply raising the hand, you cannot narrow the thoracic inlet. So there is some confusion in this. What's your feel, Dr. Ghosh?
That is described in some of the books. That is a position in which the thoracic inlet becomes slightly inward and narrowed. And plus, because you raise the hand, you are promoting the flow of blood or increasing the flow of venous blood from the arms, and thereby if there is a small obstruction, that can become exacerbated and it will become overt. What was occult previously will become overt by increasing the flow. Maybe the narrowing is such that a small amount of blood is going smoothly, but when you put a large amount of blood, then the veins will start becoming distended, and you have to hold, and you have to ask the patient to breathe in, inspiration. So raise the hands above the head and ask the patient to take a deep breath. That is the position in which the thoracic inlet apparently is the narrowest in that position.
Yes.
Although it is bony, these are joint structures. Like obviously the clavicular end of the acromial end of the clavicle will go up when you raise your hand. So maybe that will cause a configuration where the thyroid band will be compressed maximally by the soft tissue, surrounding soft tissue.
You said bones, in the diagnosis, Anish, in the diagnosis, swelling, thyroid swelling. Is it enough to say it's a simple thyroid swelling? Because you said patient has got multiple nodules in the
this is not
thyroid. Nodular thyroid.
Multinodular. So you have to either say it's a solitary nodule, or you have to say it's a diffuse goiter, or you have to say it's a multinodular goiter. You have to not just say thyroid swelling in the diagnosis. Diagnosis, at least you have to come to one of these three morphological groups. Either diffuse swelling or nodular, which may be solitary nodule or which may be multinodular. This much you have to say from your clinical examination.
And again, you say cervical lymphadenopathy. If you are saying it's a malignant thyroid, based on the history, based on the hoarseness of voice. And this cervical lymphadenopathy is what? Lymphadenopathy is a general term. You see, here lymphadenopathy is because of what?
So because of the metastasis.
Metastasis. So say that, just add that word, that the sir will be
Yes,
satisfied.
If you say
Metastatic
the lymph
survival.
node is significant, if you say is a significant, it is clinically, what is significant cervical lymphadenopathy?
Sir, lymph node more than 0.7 mm is known as in the neck, sir.
In the neck, more than 7, and the lymph node
And
should be firm in field.
Form in the heart, firm or hard.
Firm to hard. Okay.
Yes.
Fine. So revise your diagnosis. 50 years
Sir,
old lady.
50-year-old female with multinodular thyroid swelling, clinically euthyroid with metastatic cervical lymphadenopathy.
बाद में cervical lymphadenopathy बाद में आता है. Probably of malignant etiology with cervical lymphadenopathy in the level of this on the right side.
Yes.
Would you like to entertain any differential diagnosis?
Sir, it may be, sir, Riddle's thyroiditis.
Why
Okay,
jump
yes,
to riddle
Riddle's
thyroiditis
is-
first? Why riddle thyroiditis first? Why not other? You see, apart from hoarseness of voice, patient has no other telltale feature of malignancy in this patient, and most of the thyroid malignancy behaves like this. Most of the thyroid malignancy may grow slowly, but it still became malignant. So you think of other possibilities. If you take the lymphadenopathy apart, and this thyroid swelling can be a simple multinodular goiter.
Multinodular, yes.
It can be a non-toxic multinodular goiter, which may be benign.
But then it is difficult to explain the lymphadenopathy and
that's
the hoarseness of voice. So those things, keeping those things in mind, I think maybe it's better to think of something like a thyroiditis picture. Maybe Riddle's is very uncommon. You could have said Hashimoto's. Hashimoto's also will have inflammation and some amount of restriction of movement, and it can rarely cause some amount of transient hoarseness when it is in the acute stage. And lymph nodes may also be associated with Hashimoto's thyroiditis. Multinodular goiter, simple multinodular goiter, I would object. I would say, how do you explain the hoarseness? How do you explain the cervical lymphadenopathy?
Yeah, that's what I'm saying. If you have a significant cervical lymphadenopathy, then you should stick to most likely
malignancy. This is malignancy, sir. In this clinical picture, I don't think there are too many differential diagnoses.
Yeah.
So now what? What next?
Sir,
shall we go into the tests for hypo and hyperthyroidism, or has that been covered in a separate class? All those eye signs and
we have discussed. Last day we have a thyroidopsychosis case being discussed.
Fine. Then we need not go into von Graffi and Geoffroy and all. Okay.
That you discussed last class.
Fine.
So how do you proceed in a patient who has got thyroid disease? What is that classic term called as now?
Sir, quadruple test, sir.
Quadruple, not test. Quadruple assessment.
Assessment, yes.
Clinical examination is not a test.
Yes.
Quadruple assessment includes what?
Sir, history and the physical examination.
Yes, that
I will go. Yes, sir. Now I will go for the radiological examination. I will go for the USG of the neck to see the extent of the swelling, to see any invasion by the swelling, and I also at the same time I also look for the lymph nodes.
In the swelling, there are a lot of things to be seen. Ultrasonography is a very good investigation for thyroid disease. Yes. In this patient, ultrasound about the swelling, you elaborate little more.
Sir, I will see whether the swelling is multiple or single swelling, whether the swelling is cystic or solid, and
so again, like sir said when he was talking about symptoms, you go by system. So even in the ultrasound, there are certain headings. If you remember the headings, it will be easier for you. So ultrasound reporting of thyroid is classically done as nowadays. Ideally, it is done as a thyroid score, ACS thyroid score, which is very similar to the thyroid score. So what are the headings under which they report the thyroid? They get a score. So for getting that score, they see 4 headings actually. Can you tell me the 4 headings?
Sir, high risk, high risk, intermediate risk,
headings. No. I'm talking about the headings under which they see the scores.
Oh, sir.
After that, they come to risk.
Yes, sir. Sir, whether the swelling is cystic or solid?
So that is composition.
Composition.
Heading
Yes,
is
sir.
composition.
Okay,
It
sir.
can be
Yes.
solid, it can be cystic, it can be spongiform, it can
Spongy.
be
Yes, sir.
partly
Complex.
solid cystic. So,
Yes, sir.
so composition one, yes. Then what?
Then
And-
ecogenicity, sir.
Correct.
Then, sir, margins.
Correct. Then
And, sir, ecocentricity, margin, calcification, sir.
okay.
Hello.
Yes.
Yeah.
You can't hear me?
Yes, sir. I hear, sir.
Yeah. Then
Okay, so these are combined and there are scores for this. Some of them the score is 0, some of them the score is 1, for a few the score is 2. And
Yes, sir.
based on that, the ecogenicity, actually you should describe it under 2, ecogenic foci and general ecogenicity.
Okay, sir.
So if it is isoechoic with the thyroid gland, then there is low score. If it is hypoechoic,
Yes.
then there is a higher score.
High score.
Hypoechoic is a greater chance of it being malignant.
Malignancy.
Similarly, ecogenic foci, punctate ecogenic foci, that gives you a higher score. Margins, if it is ill-defined or crenated, that gives you a higher score. And the higher the score, the greater the risk of it being malignant. Fine.
Malignant.
and now apart from this, you have a situation that you can make out in ultrasonography whether the thyroid capsule is intact or not. You can
Yes, that-
even demonstrate
That
breach
is
in the
extra
thyroid
thyroid
capsule.
extent. Any standard radiologist should be able to say that. We don't get it in our city. That is unfortunate. But in the rest of India, extra thyroid extent will be mentioned in a good ultrasound report.
And next
so-
is thyroid malignancy can permeate along the internal jugular vein.
Jugular vein.
And a good sonologist can make out whether there is permeation of this tumor along the internal jugular vein course, because he can insert the internal jugular vein, see the lumen, and permeation along the internal jugular vein can be picked up in ultrasonography. Next is if it is a malignant swelling, it will be more vascular. You can apply the color coding and can see the vascularity of the nodule. That is also one of the important way to say that it's a malignant nodule or not. Okay, so you see, ultrasound is a very good investigation. You should be knowing all the important feature that sonologists should describe in ultrasound report.
What about the shape? There is one point is for the shape also. What is shape more? What is a more worrisome shape? Tall more than
So,
wide.
taller than wider.
Yes.
Tall more than wide. Yes. So that you have to mention these things. If these are, even if the sonologist does not mention a specific thyroid score, at least if they mention these words, then you should be alerted that maybe I am dealing with a malignant swelling. Well, this is a clinically very obvious malignant swelling, but sometimes, like sir said, you get just a solitary nodule in a young female, 30 years, 28 years, and slow growing history. There are no nodes, there is no compressive symptoms, and you're not sure whether it is just a colloid nodule or it is a malignant nodule. So if the ultrasound report says that there is hypoechogenicity, if there is, the shape is tall more than wide, if there are a few punctate calcification, if there is more vascularity, perilesional vascularity is more, then you should think that maybe I'm dealing with a malignant swelling.
For the
Okay.
classic features of a metastatic node on ultrasonography, classic features 1, 2, 3, 4.
Sir, first of all, there is change in the shape of the lymph node. From the bean shape, it changes to the round shape. There is a loss of fatty hilum, sir. And
Size?
size taller than wider, sir.
No, it will increase in size. It will not be. It will be
Increase.
size
Size
more
you
than
said is
You
more
just
than 7
said.
millimeter.
7 millimeter. You said.
Yes, sir. Yes, sir.
And what else?
And sir,
Fatty hilum is lost.
loss of
What
yes,
else?
sir, calcification.
Before calcification, some other thing. You see, if you insert normal node, you will find a halo around the periphery of the node. That is, as the node get enlarged, that peripheral halo is also lost. And again, like thyroid, you can see the margin of the node.
Yes.
You can make out whether there is a breach in the node capsule,
Perinodal infiltration.
perinodal extension. And then again, the vascularity. A metastatic node is hypervascular. Okay, these things you should be always, because this is asked also in the breast also. You said I'll do ultrasound of the axilla. So what are the important features of the node which is metastatic in ultrasonography? That these are the general points for any place lymph nodes. These are the important features.
Okay, so suppose the ultrasound report, you asked for ultrasound report. Ultrasound said thyroid 5. Now what?
Thyroid's 5.
Yes, there's a thyroid
Yes,
5.
sir.
Yeah.
Sir, I will go for the FNAC, ultrasound guided FNAC of the swelling.
So which swelling? This is a multinodular goiter. So which swelling will you target? You said it's a multinodular goiter, isn't it?
Yes, sir.
So there are multiple swellings. What will you do?
Sir, the swelling which has the which look more malignant or
More malignant.
I mean,
Okay,
suspicious
fine.
nodules.
suspicious.
Suppose there are two suspicious nodules, equally suspicious nodules on both sides.
Yeah. Then
Then
FNA
sir,
from FNA multiple sites. That is
multiples.
the classic description. If a multinodular goiter, if a multiple areas of suspicion, it should take multiple entry.
So, if there were two nodules on the same side, maybe I wouldn't be bothered about taking them on the same. But if they're on both lobes, then definitely I would like to have a documentation of the status of the suspicious nodule on the upper lobe, on the opposite side, because that might again influence my decision making in the overall picture. Fine. So FNAC, any blood test that you would like to do before?
Sir, thyroid profile, sir. I will do the thyroid profile test.
Entire thyroid profile. Maybe entire thyroid profile is not needed. This patient is euthyroid, but you should do a serum TSH.
TSH, yes.
TSH. In this particular patient, would you think of any other blood test?
Sir, apart from the routine blood investigations.
No, yeah, apart from routine blood investigation, we are not discussing. You are a postgraduate.
Sir, I will do, sir, thyroglobulin preoperatively.
No, that is very bad. Don't do thyroglobulin. Preoperative thyroglobulin is of no use in the evaluation of thyroid cancers. Rather, this patient is presenting in a somewhat atypical manner, aggressive manner. It's like he's slightly more old than the classical thyroid. Not very old, but slightly more old. So I would consider doing a serum calcitonin in this patient. There is no level 1 evidence for that, but in slightly atypical pictures, you should keep in mind that this could be a medullary thyroid carcinoma. It seems to be a more aggressive cancer. There are multiple nodules, there are lymph nodes, there is compressive feature. We don't get them so commonly, and in the history of 6 months, it's not like 6 years.
Yes.
So maybe I will consider that this is a slightly more aggressive variant of thyroid cancer, not the usual differentiated thyroid cancer that we get most commonly. So serum calcitonin is an inexpensive test. It's a blood test. I'm sending blood anyway for thyroglobulin. Maybe it will not hurt if we do serum calcitonin. The American Thyroid Association does not give a firm guideline for or against serum calcitonin. They have said that we leave it to the judgment of the clinician whether you will do it or not. So you need not do in all cases. It is not a routine. Suppose she was a 32-year-old lady with a solitary nodule. I was just describing smooth nodule, mobile, no compressive symptoms, no nodes, but still the FNAC or the USG is suspicious. In that patient, you will think more in terms of differentiated thyroid cancer. And maybe you need not send serum calcitonin. But slightly elderly, 50 plus, nodes are already present. There are compressive features. Sending a serum calcitonin would make sense, because again, that would, if it comes out to be high, then sometimes on FNAC, the pathologist cannot say whether it is medullary thyroid cancer. But if the calcitonin comes high, then you know for certain that this is medullary thyroid cancer, and again, the management will be significantly different. Okay.
Any role for CT scan in this patient?
CT scan will come to, sir. Imaging, so if on the ultrasound or on clinical examination, here definitely there is a hoarseness of voice, so some amount of infiltration is obviously there. So yes, I would definitely ask for a CT scan also.
No, I am asking Anish.
Oh, I'm sorry.
Sir, yes, sir.
Anyway, I have answered that. So what else?
Yes.
What else?
Sir,
What are you looking for in the CT scan? Then tell us that. What are you looking for?
for retrosternal prolongation of the.
Okay, you can see that, but if clinically you can clearly see that the lower border is palpable, and on you said percussion, the sternum is the manubrium is resonant, then it is unlikely that you will get a significant retrosternal prolongation.
In the swelling proper, what is the idea of doing a CT scan? Because patient has got some evidence of either compression or infiltration.
So,
you see, most of the suspicious features can be picked up in ultrasonography. CT is done to find out the exact extent of the swelling involving the lobes, and any extrathyroid extension, because extrathyroid extension will have some bearing on your planning of surgery.
Yes.
Agreed.
But
So, again,
but there is a criticism against CT scan. If you use a contrast CT scan, does it have any bearing in the post-op management?
Yes, sir.
What?
Sir, if we look for the if you plan for the whole body radio iodine scanning, so that will create a. Already, sir, we have given the contrast, so it will interfere with the reporting.
It may make the thyroid gland less iodine avid.
Less
So,
iodine.
because most of the contrasts are iodinated contrasts. So, we are giving a high dose of iodine in the body. So, in the later phase, when we use radio iodine, the thyroid may not take up that much. That is the only. But generally, with the time we wait for the doing the radio iodine study, the iodine in the contrast gets washed away from the body.
Usually,
so maybe
wait
it's not
for
a
about 3
significant
to 4
concern.
weeks for the iodine scan to be done.
And why we need to do it? We need to do the CT scan is like sir said, in an ideal ultrasound report you will get many information, but in India most of the time our ultrasound reports are very subjective, very variable. Without going into criticism of other, they are very variable reports. But a CT scan, you see the plates, you can see the plates yourself, and the technique is more uniform. It is not so operator dependent. Plate is more objective, so you can assess whether there is infiltration of the trachea, or whether there is infiltration of the surrounding vascular structures, the nodes, if they are there, how bulky they are. The nodes you said around level 3 and 4. So whether they are encasing the blood vessels or not, whether I will need to excise the internal jugular vein or I can get the nodes of the internal jugular vein. Clinically, sometimes it is difficult to appreciate these things if the nodes are slightly large and bulky. So these things I can better appreciate on a CT scan. The ultrasound may or may not give me this information depending on how good the operator is. So therefore, in a patient with bulky nodes, I would prefer a CT scan. In a patient with restricted mobility of the thyroid gland or compressive symptom where a nerve is involved, I will go for a CT scan to see whether the trachea is also infiltrated or not. Okay.
So what should be your, say papillary carcinoma thyroid? Give a scenario. FNA showed papillary carcinoma thyroid. Okay, what should be your next plan of management?
Sir, after the preoperatively workup, I will go for the surgical management, sir.
What surgery would you choose in this case?
Sir, in this case, sir,
in the preoperative workup, tell me one important thing other than routine, which like a test which you will not do for hernia, but you will do for this patient.
Sir, indirect laryngoscopy.
Oh, okay, fine, IDL. So especially if there is hoarseness of voice, you definitely must ask for an IDL. Even if there is no hoarseness of voice, you must ask for an IDL.
Yes,
okay, to document that both cords are actually moving properly. Sometimes there may be paresis of one cord, and there may not be any clinical manifestation of hoarseness because the other cord is compensating. But post-operatively, when it comes to light, then people will blame you that you have done the surgery and the cord is damaged. So always ask for an IDL. Agree. Fine. So preoperative work, you will go for surgery. You said what surgery?
Sir, I will go for the, in this case, sir, I will go for the total thyroidectomy with modified radical neck dissection.
On which side?
Sir, right side.
Say that. What about the central compartment?
Central.
Sir, I will not go for the prophylactic central neck.
Hey, it's not prophylactic.
Oh.
Also therapeutic, sir.
This is therapeutic. You have to do central.
Yes, sorry, sir. Yes, sir. Sorry,
which
sir.
is the draining, first echelon draining lymph node for thyroid cancer?
Sir, pretracheal lymph node. Delphian lymph node.
Central compartment. Central compartment. So if the lateral nodes are positive, you are on your clinical examination, you are not getting the central nodes positive. That is because the thyroid swelling is there in front. The nodes are behind the thyroid in the TU groove. So if the thyroid is enlarged, significant enlarged nodes may not be palpable, and even on ultrasound also they may be obscured by the thyroid gland. So if the lateral nodes are positive, you have to do a central compartment clearance. You cannot leave it behind.
Anish, what is the boundary at the central node area?
Central compartment. What is central compartment?
What is central compartment? If you go on the left side, right side, above and below.
It's the base of the hyoid bone to the suprasternum.
Then on either side?
Base of the hyoid bone. Superiorly it is hyoid bone. Yes, inferiorly it is?
Sir, suprasternal.
Acha, suprasternal, innominate vein, but okay, acha, suprasternal notch is also close enough.
And
On
either side?
both sides?
On both sides, sir. Anterior boundary of the sternocleidomastoid.
No.
No.
Mhm.
It should be the medial border of the carotid sheath.
Carotid. So
Okay.
on either side, the carotid, superiorly the hyoid bone, inferiorly the innominate vein.
Yeah.
Fine.
So
that
once
is the
central nodes are positive, central node dissection is mandatory.
Okay, sir. Yes.
And so when you say modified radical link, what level of nodes are you going to remove on the right side?
So right side, I will remove, sir. Sir, 2, 3, 4, and 5.
2, 3, 4, and 5. Very good. Fine. So no need to remove 1A, 1B. Okay. So not exactly modified. It's a posterolateral neck dissection. Okay. 2, 3, 4, and 5.
2, 3.
What about the left side?
Sir, left side, I will not. Sir.
Okay. So there you say I will not do prophylactic removal because on the ultrasound or on whatever imaging I have done, no suspicious nodes are found. So that is acceptable. You need not do. Suppose I change the scenario and say this is a solitary nodule in a 38-year-old lady. And FNAC says it is Bethesda 4. You know the FNAC is reported as a Bethesda scoring?
Yes, sir.
Can you tell me what is Bethesda 3, what is Bethesda 4, what is Bethesda 5?
Sir, Bethesda 3 is ATP of undetermined significance, and Bethesda 4 is the follicular neoplasm.
Of undetermined significance, yes.
Undetermined significance. And sir, Bethesda 5 is a highly suspicious of malignancy.
Highly suspicious. What is the risk of it ultimately turning out to be malignant in a Bethesda 4?
Bethesda 4, sir, it is 50 to 75%.
No,
that is too high.
Too high.
Around 30%. Bethesda 4, 30%. So now you have got a Bethesda 4. This scenario I said, 38-year-old lady, 2 centimeters swelling, solitary nodule, no nodes, no compressive features. USG is maybe TIRADS 4 or TIRADS 5. Let me say USG is TIRADS 5. But Bethesda is Bethesda 4. What do you do? She is very anxious to avoid surgery. She is very anxious about her voice. 28-year-old girl, not even married maybe. Doctor, your colleague.
Sir,
you tell us the options. What can be the planning in these patients? Options 1, 2.
So we can go for the simple lobectomy, sir. For this, and sir, or we can go for the radioactive ablation.
Radioactive ablation of a
you don't have evidence of malignancy. All suspicious.
Sir,
what is the rationality of doing only lobectomy versus a total thyroidectomy? Some people might say, I'll do a total thyroidectomy in this situation. Or lobectomy and then decide what should be the more rational approach.
Sir, lobectomy and then decide.
Why? What is the point in favor of your decision that you go lobectomy? If it is a Bethesda 5, high suspicion of malignancy. Can it be the sole treatment for some malignancy? You do only a lobectomy?
Sir, if the size of the tumor.
I gave you the size, 2 centimeters.
Sir,
you got my point. Can lobectomy be a treatment for thyroid malignancy?
Yes, sir.
Yes or no?
Yes,
so
sir,
which patient? So which patient you will say, okay, I will just do lobectomy. I will not do total thyroidectomy. Which patient?
Sir, if the means type of
carcinoma,
sir, it will depend.
This is a female patient. Who are the low risk patient? Who are the low risk patients?
So do you know of risk stratification scores or not? Ages and AMS.
Ages and masses. Yes, sir.
Masses is a post-op score. Extent of resection. You see.
Yeah.
Completeness of resection. You may see. C is completeness of resection. So obviously, if they are talking about completeness of resection, it is a post-op score. Otherwise, there is no question of completeness of resection. So let's leave masses out. but let's
Yes.
concentrate on ages and aims.
Yes, sir.
These two are pre-operative scores. You have not done the operation, and they can help you to decide on whether to go for a hemi versus a total. So
Yeah.
if it is a low risk patient, like say less than 50 years in female, less than 40 years in male, if it is a small nodule, let's say less than 1.5 centimeter in size or less than 2 centimeter in size, if there is no extra thyroid extent on imaging, on clinically
Yes.
also there is no compressive symptom, then and on the FNAC there is no atypical histology, there is no bad histology. Like, do you know what some of the bad histologies are in differentiated thyroid cancer
Yes,
on
sir.
FNAC? What are they?
Sir, tall variety of the papillary
Tall
carcinoma,
cell,
insular
tall cell
variety,
variant. Yes,
tall
tall
cell
cell.
variety,
Then
insular variety of the sir, papillary
correct,
cell
insular variety is one.
carcinoma.
Then
Sir, sclerosing variety of the papillary cell
diffuse sclerosing,
carcinoma.
not sclerosing, diffuse
Sclerosis.
sclerosing. Then
Yes, sir.
columnar.
Columnar.
So
Yes.
these are all bad types of, these are also differentiated thyroid cancer, but they are poorly differentiated thyroid cancer. Tall cell variant, columnar variant, insular variant, diffuse sclerosing variant. So
Yes, sir.
in the, if none of these histologies are present on FNAC, the pathologist has not said any of these things, then
Yes.
a lobectomy or a hemithyroidectomy is adequate treatment for a low risk differentiated thyroid cancer.
Yeah.
But if there are high risk features, elderly, extra thyroid extension is present, there is suspicion of the one's adverse histology on FNAC, or there are multifocality, or there are lymph nodes, then
Yes.
the treatment of choice would be a total thyroidectomy. Then you cannot do a hemithyroidectomy or a lobectomy. Then you will not be justified. Okay. But
We
in a
discuss post-op.
Bethesda 4,
Dr. Ghosh,
sir,
we discuss some post-op and follow-up.
sir, are we running out of time?
Yes, almost 5 minutes.
Oh, we are running. Okay. Please, but just one line, sir. If it is a
Yeah.
Bethesda 4, first of all, don't say radioiodine ever. And in
So,
Bethesda
yes.
4, in most people would go for a lobectomy, not for a total thyroid. Bethesda 4, but you have to explain that if on the final histopath it comes out to be malignant, the chance of which are 30%, and there are adverse features, then I might have to do a completion. But that is very less. Just if it comes out to be malignant, the lobectomy may still be adequate. We just discussed. Even in Bethesda 5, in a proven cancer, lobectomy may be enough. So you have to discuss with the patient. Okay.
Yes.
Provided the other lobe is normal. You have to say that the other lobe is
Other
normal.
lobe is no. Of course. In a solitary node. If it is a multinodular, then of course you have to consider doing something for the other lobe also. Okay, fine. So you have done total thyroidectomy, you have done level 2, 3, 4, 5, and you have done central compartment. So now histology comes out to be papillary thyroid cancer, ET present, LV present, no perinodal perineural invasion, 7 out of 22 lateral lymph nodes positive. Now what? And 1 out of 4 central compartment nodes positive.
Sir, then I will. Sir, I will follow up the patient after 3 months. 3 months.
3 months.
Follow
What is
up
the
patient
discharge
for 3
advice?
months, no adjuvant.
Sir,
What is
Sir,
the
sir.
discharge advice? What is the you are discharging patient after 3 days? What is the advice now? Patient is going home.
sir, I will send patient with normal protocol of the normal surgical discharge protocol along with the levothyroxine, along with the
Levothyroxine.
No.
That is I asking.
Doctor.
Discharge advice will not include L-thyroxine at this stage because Dr. Ghosh has given a scenario which is very locally advanced disease.
High risk patient. These are high risk patients.
High
They
risk
need
patient, locally
adjuvant
advanced disease.
radioactive iodine. So
So
what are the
you,
things that you have to do to allow the patient to get radioactive iodine?
Sir, we have to keep the TSH level high.
So how do you
don't
get
start.
that?
That is asking.
Yes.
Discharge advice will not include L-thyroxine.
Include the levothyroxine. Yes.
You discharge the patient on 3rd day. Ask her to come back after a week for your review of the operative site and exclude any post-op complications like hypoparathyroidism.
Dr. Anish, I am interrupting. Sir is discharging the patient on 3rd day. Personally, I will never discharge my total thyroidectomy patients on 3rd day. Can you tell me why?
Sir, hypocalcemia. Yes,
Yeah.
sir.
When does hypocalcemia most commonly present?
So 3rd day, 2nd to 3rd day, sir.
No, at least when I used to be a student, it was taught was 4th post-op day is the most common. So I will definitely keep the patient for 4 days at least.
Yes.
So most common presentation of hypocalcemia is on the 4th post-op day. So I would keep it for 4 days before sending the patient home. Okay, so that is a different issue. Sir, I think we need one more class for just post-op complication and management and adjuvant therapy. Otherwise, there is no time.
Yeah. So
So
basic thing is don't start the L-thyroxine. Discharge the patient and come back.
iodine-free diet, not just L-thyroxine. You have to mention that.
Yes,
So
sir.
no betadine ointment dressing, no cough syrups,
No
no
added salt.
no added salt extra, no outside food like tandoori masala or seafood going to a restaurant.
Yes.
For how long? For how long? For the rest of her life.
No, sir.
So when will you ask the
Sir,
patient to go for the radioiodine therapy? She doesn't know anything. You have to tell her.
sir, after 4 weeks.
No, 4 weeks is generally a little too early. The standard is 6 weeks. We have to wait for the TSH to go above
6 weeks. So 50.
above
50.
no 30. 30 is enough. Above 30 is enough. In 6 weeks time, generally it will go up to 50, 60, 70. In a young patient, it goes up to 100. So suppose the patient is, this lady has also got cardiac disease. She is not 50, she is 65 and she has got cardiac disease. And the hypothyroidism that will ensue is problematic. Can you do something else? Or she is very high profile. She is the CM of the state. She cannot afford to be waiting 6 weeks in a hypothyroid state. She has got a lot of important meetings to go to. She needs to be functional. Can you
Sir,
shorten this period? How can
Sir,
you
I can inject the recombinant TSH.
No, before
Good.
that,
Sir, I can use the
you have T3 available in the market now.
Levotriiodothyronine. Yes, sir. 7
Exactly.
days.
So that is
You
a
have to
shorter
stop it
half-life.
7 days.
So shorter
Yes.
half-life. So you just need to stop it for 7 days. And even then, if the TSH doesn't go up, you can give recombinant TSH. But it is very expensive. One injection of
Yes.
recombinant TSH costs around 55,000-60,000 rupees. So you have to give 2 usually.
Yes, sir.
So
Yes.
that is more than 1 lakh just to get the TSH level high. So only those who are affording can get it. But it is an option, yes. So those who don't want to have this prolonged period of hypothyroidism, they can go for that. So you should know that option is there.
Yes.
Okay.
You have done a whole
So-
body scan. What do you look for?
Sir,
Whole
I
body
will look
scanning
for
is done. What are the things you look for in whole body scan?
Sir, I will look for the any uptake, sir. Iodine
Where?
uptake in the neck and in the body, sir.
In the neck and rest of the body.
Rest of the body, yes, sir.
So generally, do you know how much dose is given in the first year?
Sir, it is 5 microcurie. For
Three millicurie. 3 millicurie.
Millicurie. Yes.
This is little more in whole body scanning. In a routine thyroid scanning, you get 5 microcurie.
Yes, sir. Okay, sir.
Now you have good amount of residual tissue in the neck. What should be your
Yes, sir.
strategy in the post-op period? After 6 weeks, you find there is a good amount of residual tissue in the thyroid bed.
Sir, I will go for the radioactive ablation.
Remnant radioactive ablation.
Remnant
Yes.
radioactive ablation.
Fine. So and after that, they will do a post-therapy scan, PTS. 48 hours
Yes.
after the giving that is the remnant dose is generally they calculate, but generally 30 to 50 millicurie they will give, and 48 hours after they will do another scan. And if there is no activity elsewhere, then they are satisfied. They ask you to come back after 6 months. If there is uptake elsewhere, then they again have to consider giving a second dose. Do you know the total cumulative dose that can be given?
Sir, 150 to 200.
No, much more than that. Initially, it used to be one curie. Nowadays, the ATA is more worried about the dose, and they have tried to reduce it to around 700 to 800 millicurie. But
No, that should be a total dose, maybe
total,
cumulative.
lifetime dose.
In one dose, you usually gave 100 to 150.
Yes.
So
What is the
why
follow-up
do you-
protocol? Anish, what is the follow-up? You have given the patient radioablation, and then what is the follow-up treatment?
Sir, follow-up treatments are lifelong, sir, suppressive dose of the thyroxine.
Is it suppressive or what? There is another term being used. It's not only
Sir.
suppressive dose. It is supranormal dose.
Supraphysiological.
So what is the
Supranormal.
range of TSH that you're looking at? What is the range of TSH that you want to keep the patient in?
Sir, less than 0.1.
In all cases, less than 0.1 in all cases? Or is there a low risk and high risk division?
Sir, in high risk cases.
And low risk cases?
0.3, sir.
0.5, less than 0.5. Between 0.1 and 0.5 is enough for low risk cases. Okay, then suppose there is a recurrence. Do we have time, sir?
Just 2 minutes.
2
9
minutes we
o'clock.
can take. So suppose there are lung mets. Now the post-therapy scan is showing multiple lung mets. Can you do anything?
Sir,
You can use
conservative.
radioiodine. More conservative. What is conservative?
Sorry, sir. Sir,
You can use radioiodine for lung met.
okay, sir.
What is tennis syndrome?
Tennis.
Yes, tennis syndrome. Post-op you are following up, and now the patient comes with tennis syndrome. You have any idea?
No,
Thyroglobulin elevated, negative iodine scan. You follow up the. How do you follow up the patient after total thyroidectomy? You ask for ultrasonography and you ask for
ultrasound and
serum
clinical examination.
TG.
Serum
TG, no,
thyroglobulin.
TG also.
Yes.
TG also.
Yes.
Yeah, now you use TG, not in the pre-op. Now you use TG, and after a total thyroidectomy and after ablation, TG should be virtually undetectable. TG can again be, it can be unstimulated or stimulated, or unstimulated is also known as suppressed. So that is, you can stop the thyroxine supplementation for around 4 weeks and then test the TG, or you can keep the patient on thyroxine supplementation, not ask him to stop, him or her, and ask for blood test. But you have to keep in mind that which value you are looking at. Are you stopping and testing, or are you continuing thyroxine and testing? So whether it is suppressed TG or whether it is stimulated TG. So anyway, suppressed TG should be virtually undetectable. Stimulated TG also maybe up to 10 is acceptable. But if it is more than 10, although it's a total thyroidectomy, ideally you should not get any TG. But in practice, we see that always TG is there. It is never actually undetectable. But if it goes above a certain value, then you have to think that there is recurrence somewhere. So thyroglobulin elevated. What do? But the radioiodine scan this time is not showing anything. So that condition is known as tennis. Thyroglobulin elevated, negative iodine scan. So now what do you do? There is a recurrence somewhere, but
I will go for the PET scan, sir.
Okay, that's a good solution. You can go for HCT, which does not specifically depend on iodine receptor. It just depends on metabolic activity. So, some nodes in the neck, some nodes in the mediastinum. Now what?
Sir, again go for the radioactive.
No, but now radioactive will not work. Radioactive will not work because it is already not showing on the radioactive time. It has become de-differentiated. It is becoming poorly differentiated now. So it has lost the sodium iodide symptotem. Can you use some drugs to get it back?
Sorafenib and
no. Sorafenib is a specific drug for treatment. I am talking about iodine sensitive sensitizers. Any role of retinoic acid, any role of lithium?
Some no idea, sir.
Yeah.
These things may be used, but some people have said.
Okay.
Okay. Thank you, Dr. Ghosh. Thank you.
Okay.
Thank you, sir.
Thank you very much.